In this session, we're going to discuss the critical role of secure and integrated health data sharing, of university, government and industry partnerships, and multidisciplinary collaborations for big data to be able to advance national and global health outcomes. We're going to learn how we can collectively harness digital health resources to deliver value, to enhance safety and quality of care, to empower the health workforce, researchers and policymakers for the benefit of all Australians. I'm keen to hear about your experiences with access and use of clinical data, of administrative data, public health data, multi-agency data and research data. The practical issues that you've faced in getting access to and using that data, and what has worked well that's helped make the most of those resources. To do this, we've got a wonderful panel, and I'd like to introduce the panel members as they come up. First, Associate Professor Ben Hachey. So Ben is the Beamtree Associate Professor of Clinical Informatics and Data Science at the University of Sydney, and he co-chairs the Synthetic Data Community of Practice. His background is natural language processing research and AI engineering leadership. He led the applied AI team at Harrison. That might be an interesting conversation to have. Shipping models that power diagnostic assist tools for chest X-ray and brain CT. And in addition to AI implementation and validation, his mission is to deliver data solutions that improve scale, quality and maintenance of AI to improve outcomes and experience. Our second panellist is Professor Stephen McPhail. He's a health services researcher, health economist and clinician with a special interest in digital health and AI implementation and sustainment. He's director of the Australian Centre for Health Services Innovation and the Centre for Healthcare Transformation at the Queensland University of Technology. Stephen is passionate about empowering health services to deliver high-value patient-centred care, particularly for vulnerable members of our community. The third panellist is Dr. Natalie Smith, who is Associate Professor in Practice with the University of Sydney. Her passion is in helping boards, executives and clinical leaders obtain value from investments in digital and health-empowered transformation. Natalie's focus is on the governance of digital and data transformation, and she gets to test this in practice with a number of board roles that she has. And finally, online, we have Professor Claire Sullivan. I'm hoping that this is the point she magically appears. There she is. Hi, Claire. Can you hear us okay?
I can. Hello, everybody.
Excellent, fantastic. So she's joining us remotely from Queensland. She's an internationally recognised leading practising and academic clinical informatician, helping to drive digital health and transformation. She's director of the University of Queensland's Digital Health Centre and serves on several national advisory boards for digital health, and she is the chair of the Australian Council for Senior Academic Leaders in Digital Health, which is sponsoring this session with the Academy. And I'm pleased to acknowledge Associate Professor Annette Schmidi here in the room too, who is the Chair and CEO of the Digital Health CRC, which gave birth to the Council of Senior Academic Leaders. And Claire, I wonder if we can just actually get from you to start with a little bit about your new council, which you're chairing and which I have the privilege of serving on with you.
Oh, thank you. Hello, everybody. I'm from Brisbane today. It is wonderful to be here. I think that the council is a recognition that digital health is shifting from a technical endeavour to one that requires academic leadership. So I think digital health really started out as IT projects, if you like, and there's now increasing recognition that an evidence base is needed for digital transformation in health. And we're very proud that we have 37 universities joining this council. We have the leading minds from each of those universities banding together to help form an evidence base to advance digital transformation in a way that is safe, effective, consumer-centred and efficient. So we look forward to continuing to interact with the Academy over the coming years.
Thanks very much, Claire. Now, we've had a wonderful session this morning, and thank you, Alistair, for leading it with the keynote presentation and then the panel that you've chaired. And in many ways, this conversation continues that conversation, and I know there are a lot of questions that didn't have the opportunity to be asked in that last session, and feel free, I think, with the eminent panel that we've got here to raise those. I really want to hear from all of you in the room about your experiences accessing and using data and the challenges, because we've got some of the people here who I think will have some success stories about how to overcome the barriers, and that's really a major goal of this session. So perhaps if I can turn to the panel to start with and really just ask you, where are we at with the big data sets, particularly the clinical electronic health records in Australia, and making them useful for research and advancing healthcare? And perhaps Natalie, I'll start with you.
Yeah, thanks. Not nearly as far as we need to be, and I sit on the board of Uniting Care Queensland. I'm involved with St John of God Health. And get insight. Sorry about that. Get insight, I guess, into what's happening, particularly in the private health space and also in the public system. Even within our own organisations, we're having trouble sharing data, and the barrier for us really is financial. I know you've been following or probably see what's happening in the private health sector. Dire straits, technology, data sharing still seen as a cost rather than, I guess, the way that's going to get us out of trouble. So we've got a long way to go.
Steve, what's your experience with electronic health records in Queensland and further afield?
Sure. Let me. That answer could be very boring and tedious for a lot of people. So let me cut to the chase. So when we I was working with Claire at this time at PA. We went from being perhaps the most analogue hospital in the world. Claire, if you think that's a fair summary. We were very, very analogue to being completely digitised, and of course that pretty much fixed all the problems. No, that's
the theory. Right?
That didn't happen, of course. But I guess through those experiences, though, you learn to understand the role of electronic health records as more of a library. And actually, I think, Claire, I might have even got this analogy from you, perhaps. We have information, it's stored, and now we need to find out ways we can use it properly, do things. We need an index for the library as for a start. I think a lot of the times when we're starting with EMRs, even across Australia right now, within a health system, people don't actually know the index for their EMR in terms of how to extract information for research purposes, for informing quality improvement, without it being very laborious. And so that's challenging. And then just to carry that a step further, is that when you go to a library, the book has usually been curated in some way and edited, and you can trust that the words in there are likely to be coherent and make sense. When we have EMRs that are filled with unvalidated data that can be messy and unstructured, it creates a lot of challenges then to carry that forward. And the level of digital maturity across our health system, even among hospitals with EMRs, varies widely. And we have some that are at a more advanced stage, and then others, and some who you might think are at a more advanced stage, but are still really struggling to really bed down the basics of ensuring that the data is valid, reliable, and accessible. Before we even get to the issues related to governance and so forth, which we'll probably touch on. Yeah, that's probably enough.
So can I just get a show of hands in the room? Who's working in a fully digital system, paperless at the moment? Hands right up. Okay, there's a few of you. Who's working in sort of a hybrid, half-half, paper and digital? Okay, and who's not got a digital electronic health record in your organisation yet to speak of? Nobody? Okay, well, there's a couple. There are a couple, okay. That's interesting. I'd love to get just a perspective on your transition from paperless to digital and where you feel you're at. So just maybe if we can get a couple of people to put your hands up, and you've got a story to tell, the microphones will come to you. Ben, you've been in the private sector. You're also now in the academic sector. What lessons are there from one to the other about pace of movement, transitions, how we go to a fully workable digital health record?
Interesting question, thanks. So I've gone back and forth. I was in computer science 10 years ago and have been in industry for a while, and then back, but focusing really on health AI within Faculty of Medicine and Health at University of Sydney now. I guess EHR is an interesting starting point as well. But with EHR, what we're hearing right now is it's taking researchers 2 years to get access to data. And the impact of this, of course, is that we're dramatically throttling the amount of good research that we're able to do and the potential beneficial outcomes of that research. It's kind of hard to say what the lessons are from industry, but I mean, I guess in industry, you might not wait two years to get access to data, right? That would be a long time to wait around and have your investment just sitting there and not building something. So. I guess this is the real barrier, I think, is we really need to figure out ways to streamline the governance so we're unlocking these good, the beneficial outcomes.
So, I don't mind me asking about Harrison AI. It's been in the media recently, and there must be some learnings from the access to personal data that Harrison's had, and it's been the topic of conversation. Do you want to just take us through your perspective on what that story's been about?
Yeah. So clearly Harrison's been in the news recently. Maybe just to add, just to say a little bit about the background there, right? So Harrison and maybe more so IMED, being the clinical custodians of the data, have come under fire from originally Crikey, I think, was doing the reporting and regarding the way that the data is accessed and what it's being used for. At the moment, I think the current status is there's a OAIC investigation that's been started recently, and they're looking at that, which is a good thing. I mean, I believe that that best practice was followed in terms of accessing the data. Well, maybe not best practice. Maybe it's more accurate to say that legal and regulatory frameworks were followed appropriately. My feeling is probably that the lesson from this is that that's not enough. We have to follow regulatory guidelines and legal guidelines, but we also need to have transparent governance and social license for this work.
Yeah. Who's got an experience? There's up back there.
Thank you. Stephen Tong from University of Melbourne. So I do a lot of different research, and perinatal epidemiology is a part of the portfolio, and just two very contrasting experiences. So the first is there's a big epidemiology team trying to link data from different agencies in Victoria, and it is immensely frustrating because you collect the data and you send it to de-identified data and someone links it for you. It's a monopoly, and they're slow and possibly not the most helpful of a pathway. And then you might just forget a field, and that's a complete disaster, setting you 6 months back, and the phone's off the hook, and it is just very difficult. You just have to hound and advocate, but the monopoly thing's frustrating. The second experience, I work with a Swedish group, and that's just a complete privilege. I just come up with any question and they can answer it within a month or two. It's just absolutely astounding in the differences. And just, if there's something which, I'm just a newbie, but what the Academy could advocate is trying to get these monopolies moving so we can free up the data for research.
So I presume you're talking about state health department data mostly there?
Yeah.
But I think I'm seeing heads nod, but I'm sure there's similar experiences with Commonwealth data and prior to WASMATA, multi-agency data integration. Yep.
Thanks, Helena Ted from Monash. Just to build on what Stephen was saying, we've just mapped the data landscape nationally and in Scandinavia and Australia. There is about 15 data custodians. They're fiercely territorial. They use different definitions and are very resistant to change. They don't share their data transparently, not just the technical issues. And even if they do, if you go to AIHW, it can take up to 4 years to get maternity data. And then when you get it and you go through all the ethics and all the funding and all the analysis, if there's a politician who doesn't like the message that the data and the research shows, they can squash the publication that is 4.5 years in the making. There's a major conflict of interest. The data landscape is seriously broken, and there is about to be a very controversial publication on exactly that. But in Australia, our jurisdictional system is a huge limitation.
Thanks, Helena and Stephen, for those comments. I'm seeing lots of heads kind of nod around. Claire, can I turn to you? This obviously seems like a major barrier to being able to link and use data effectively in a timely fashion. What are your thoughts?
I think we're in a period of great change. So we are seeing the digital disruption of research. So for hundreds of years, we've been reductionists, haven't we? Trying to generate pure data under perfect conditions. And that data was generated by the scientists, it was owned by the scientists, so it was easy to control. We're now all interested in real-world evidence. And real-world evidence means that we do have to use data that is collected during routine healthcare. That is at odds with the primary use of that data. So we're going through a period, I think, of self-examination and disruption as we understand how to utilise that real-world data to generate real-world evidence. And as scientists, we're able to say not only does this work under perfect conditions, but can this work in real-world conditions? And so I think trying to frame it as a shift from reductionist science to embracing complexity and system change is going to be an important way to articulate the value back to the data custodians. I agree with Helena, we do need to help people understand the value of utilising this real-world evidence. And one thing I've always found useful is to also articulate the consequences of not using the data.
Right.
So not only do we talk about our publications and our 4-year wait, but let's talk about what happens if we don't know what's happening. How do we improve and how do we make that quality better? So articulating the consequences of not using the data as well as the risks of using it, I think is important.
So do you mean actually translating that into lives lost, dollars,
Correct.
extra dollars spent,
Correct.
inefficiencies in the system, so on?
Yeah.
A language that speaks to policymakers.
Yeah.
Okay. Flavia and then Sharon. Yeah. Microphone. And just while Flavia's getting the microphone, I'd love to understand a little bit about what the data access environment is like in the UK and in Canada. If we can get that
So
input.
one of the things I would like people to comment on, like for example, I'm in Victoria, I'm at the Alfred Hospital. The EMR works reasonably well in the Alfred, but Alfred set up Cerner. Other state-funded organisations in public hospitals use different systems. None of them talk to each other. None talk to the private pathology providers. So in a way, we talk about, oh, isn't it terrible you can't link data? Well, you certainly can't use hospital data, and Cerner owns it. If you try and do a study, it's almost impossible to access any of the data. And the other thing I'd like to just throw in the mix, in general practice, there's only I'm not in general practice, there's only 2 or 3 providers. They own the data. They actually own it. So GPs pay to use the, whatever it is, medical director or whatever, but medical director owns the data. So there's a whole lot of, and yet it's all Medicare funded activity and so on. So we've got some really crazy systems going on.
Can I just check that? Who does own the data? Is it right that Cerner owns the data or medical director owns the data? Or is it patients'
We've,
data? Or is
we've
it
just been
clinicians'
having,
data?
I don't think we're very clear on it, to be honest, until it starts to become an issue, I guess, as it has with Harrison. But we had one, you know, on the board where dealing with the insurance providers, and one of the negotiations, as you know, it's been quite topical, was to have more access to data. And, you know, as the negotiators were thinking about that, I'm going, guys, that isn't our data. Like, it's our patients' data, it's not even our data to be able to, like, I think even at an organisational level, we're struggling with that. So yeah, I think we need to get much clearer on that, and I think in some cases change where the ownership lies. Another example I'll give you outside of health is training an AI solution to do with mobile phone detection. Government had to let the AI provider in to train on the government data because they don't have those big data sets. In effect, gave the data away. The AI provider is now a multimillionaire from this AI solution that they changed. So, you know, who should be making the money from that? So I think we need to be much clearer on who owns and who profits from the data.
Stephen, Ben, you got thoughts on this?
One, I'll just offer sort of a side comment, but I just want to call out and acknowledge some of the really great work happening in the community controlled sector. And I think in particular of the Aboriginal and Torres Strait Islander Community Health Service in Brisbane, who have been really thoughtful about this. And they've not only engaged well with their own policy reform, but also practically. And so when a community member comes for an encounter and they may do an assessment of some kind, it doesn't just get filed away in the file and becomes, you know, in the office. They actually give a copy to the patient. And they say, this is yours, this is your goals, this is your information, you own this. And we have a copy of it because we're here to empower you and it's on your health journey. And I think that's really powerful. It's powerful in more than a data governance way. It's powerful because it's actually engendering agency, you know, among their community. And I think we could all learn from that. And that should be sort of accredited and acknowledged that there is thoughtful things happening. It's I believe we're not doing this so well in the government public sector organisations. One of the real challenges, I think, which is what is data? I mean, that sounds like a stupid question, but like when you had, do you remember when you used to get a video from the video store back in the, I don't know, whenever we had videos, I can't remember, it was that long ago, I was a kid. And there was like and it was really hard to copy them. They did something to it that you couldn't just copy it at home. Then you got to DVDs and they tried to do that, but you could actually get ways around that and you could make lots of copies of the DVD. And then there was this free-for-all pirating of everything that seemed to happen for a while. And so while this stuff's happening, what is the data? What is the data? Well, there probably is some original data source back in Hollywood for that movie. But actually, it's everywhere now. And so when we think of health data, we often think of it as a singular thing. But actually, it can be duplicated. It can sit in many places. Maybe it shouldn't. Maybe it should have a single home. Maybe it should be governed. And for research, and I think we can see this in other countries, the Scandinavian example is brought up as a good one. Estonia is another, which is very close to Scandinavia, I guess. But the where we have platforms, secure platforms, where researchers can access data without actually taking it away, and so it can stay in a secure environment without it being taken away. And I know some of the work that we're doing, and Claire's leading actually with federated learning, and currently is looking at opportunities there as well. But that's probably enough for me. I'll let someone else.
Well, Claire, do you want to follow on from that?
Yeah, look, that's a great analogy. Steve, I used to work in a Blockbuster, just so you know. So there is new technology now that I think helps us with the issue around who owns the data. And we're very fortunate to be working, Steve and I, on an MRFF-funded grant that accepts that data sovereignty is going to want to be retained in the place where it's generated. It accepts the cultural norm, which is currently here, that people don't want to send data across jurisdictions. It uses a technique called federated learning, where instead of the data being linked, code is sent instead to each database, and the code goes through the database, performs the analysis, and then brings the analysis back to the researcher. So no removal of data, no exposure of private details to the researchers, simply the learnings come back. So we're doing that at the moment with what we call federated analytics, where we can do simple counts, but our new project is around actually using machine learning and artificial intelligence to help gather those learnings and those analyses and bring it back to the researcher. So I don't want us to be stuck in that paradigm of having to physically shift data around or who owns it. I think that there is new and emerging technologies which will obviate some of that and I hope streamline the processes.
So you still got to get the data and get access to it. And I'm sure everybody in this room has had some experience of someone being a data custodian and feeling like they have control over access to a data set, whether it be a hospital data set or a government data set or whatever it might be, and then putting up barriers. And they might be well intentioned in doing so, thinking they're protecting the patient or protecting the data from misuse or whatever, but we've just heard from Stephen, a sort of a 4-year experience and 6 months delay when one data item gets miscoded or something. What should we do when we're confronted with that sort of response, when we want data for research or practice improvement purposes?
I mean, I think you sort of hit the nail on the head, right? People are doing it not out of malice, or not because they want to slow down research, but because they're following guidelines and a regulatory environment. And I think there's a lot of uncertainty there as well. So I think I was really, really encouraged by the presentations this morning and all of the good work happening there to I think, provide certainty and basically put processes on rails as much as possible. And I think that we could do a lot of that and adapt a lot of that in Australia to have more standardized procedures, processes, work instructions for how we manage data, how we track how data is being used, as well as the physical or digital infrastructure like trusted research environments and federated learning.
Well, Alistair, Sal, could I ask you to comment on, can we get a microphone over? On the UK experience. Can we get the Canadian experience on this too?
Okay. Well, thanks for this opportunity. If I start and Shao, you can fill in. So I just made a couple of notes. I wasn't texting. I was making some notes as you were talking. So from the UK perspective, we're seeing all the same problems. We're just the amplitude of some, maybe more in some areas and less in others. But it's similar issues. A couple of notes I made. One is what we're trying wherever possible is to focus on aligning the quality of the data, which a number of you mentioned, for all purposes. So it doesn't make sense to try and improve the quality of clinical care in one place and then improve it for research in another place and then for quality improvement for another. So let's try and make sure that from the whole process of capturing the data all the way through to kind of curating it, it happens once as far as possible, so it's not redundant effort. You mentioned secure data environments and trusted research environments, and again, we've taken that model at a regional level. So I've lost count, but I think there's 12 across the UK. What we're finding is it's really good for discovery research. So the idea that researchers come in to use the data in that environment, so it's under governance of the health service. It's very good for public trust. It's very bad for developers of data-driven technologies, for AI companies. So it's not the answer to, or at least in its current format, it's not an easy answer to everything. But the other thing that I just was going to draw out related to the way we've been handling data, which I'm sure you're doing the same here, is having public and patient-led data access committees. So the idea is that is obviously that you do that effort to get the data into a safe space wherever that may sit, but then the guardians of that are public and patient representatives on behalf of that community. Yeah, that's all I'll say. Shall anything?
Great. Melissa, yeah.
Yeah, happy to comment from a Canadian perspective, and it speaks to a lot of what I'm trying to set up here. So one of the, like, I don't disagree with any of your comments. I've been finding the same thing, that it is a little bit unclear. And so one of the motivating factors for us was that one place where it is clear is in research ethics governance. So we have, for decades now, enabled the secondary use of data that was initially collected for clinical purposes. So in Canada, we have very clear carve-outs in our privacy legislation that says any use of personal health information that pertains to health research, it's the Research Ethics Board, or the HREC, that governs that. So at Sick Kids back in 2019, we set out to provide a pathway for researchers to access clinically collected data, including what we would call like pseudo-identifiable data. So for example, in pediatrics, we need to know if you're 2 weeks old or 4 weeks old. We can't just say, you know, you're X number of months. Similarly, for a lot of procedural things, we need to know the specific dates, because sometimes our practice guidelines change, or there might be shifts in the environment that we need to know about, so we need some specific identifiers. And so the pathway to do that is through the Research Ethics Board. And we definitely did make modifications. So rather than having a specific project, we enabled whole teams to access clinical data. A number of our teams also embedded basically a bit of programming. So where we had a high rate of patients who were First Nations who said, I don't want my information to be used for research. So out of respect for Indigenous data sovereignty, we were able to code so that those records were not extracted. But through the Research Ethics Board, we enabled this large-scale access to clinical data, routine extractions, some teams as much as every 5 minutes. And I remember when we first opened this up, we had 20 team applications. There's over 100. And I feel like I can rather confidently say, because I've gotten this feedback, that no one has an issue with data access at Sick Kids. And we operate under the rules that we know to be important to health research, which is protecting data. We do also share data, because we're pediatrics. So we have small numbers relative to adult populations. So we share with other hospitals, again, kind of under controlled data access use agreements. We do also share with industry sometimes, because we do partner with pharmaceutical companies. And so making sure that we're very clear about what aspects of the data go to those industries and which ones do not. And part of that is overseen by the consumers. And I've really resonated with your comments, because in some ways I think we talk a little bit about, you know, this issue of data ownership. But I think what I hear most from our patients is that they want exactly that. They want some agency over it. They're generally quite happy for people to use information for health research, but they want some reciprocity. They want some benefit to themselves to know that their information went to something good. So I think that that's the clearest pathway that I can see for us. And so I think it's a matter of enabling and empowering our HRECs to be able to conduct a thorough ethics overview. And again, kind of similar to my comments before about preparing our researchers for publishing at a very high quality level, making sure the documentation of the data that they're accessing is thorough, that it's going to address important aspects of fairness and bias. So that's sort of my thought.
Thanks, Melissa, and thank you, Alistair. And I'm keen to hear from anybody else who's got a story about what's worked. Yes.
Thanks. This is perhaps a story about what doesn't work very well. We've talked about clinical data and research data, but I'm thinking of a situation of communicable disease control where we're trying to integrate laboratory data, and particularly in recent years, genomic data, with clinical data and public health data and action, all of which has to happen if it's going to be effective in real time. It's not research, although a lot of people think epidemiology is research. It's not. It's real. It's practice. But integrating all of those things has been an enormous challenge over the years, and even 2 or 3 years of COVID didn't stop the barriers between laboratory, clinical data, data across jurisdictions continues to be an issue. When you're talking about disease control, those sorts of barriers really do make a problem. They're intrusive. There are ethical aspects about who owns, for example, microbial strain typing data belonging to that comes from a particular patient, because it can actually tell you quite a lot about that patient. But nevertheless, in the context of a disease outbreak, somehow those barriers need to be overcome, and they haven't been yet, I think.
Is that a technical problem?
No, no.
Or
well,
an access problem?
Not really.
Or both?
It's not a technical problem. It's a problem of, particularly between laboratories, clinicians and jurisdictions, the sort of paranoia of data sharing, private patient data between those agencies and professionals, which is always a bit of a worry because the people don't trust each other. But there's a lot of problems in sharing data between jurisdictions. Sometimes it's just because of different systems that don't talk to each other, but it's often because of the legal branches of health departments who refuse to allow people to share.
So should health emergencies be a special case where
well, you'd
different
think they
rules
were.
apply?
There's legislation covering them, but it doesn't always translate into practice.
Right. Natalie?
I just think that's a really key point. I don't think the issue with sharing data is a technical one for the most part. It's to do with trust, and it's also to do with, I think we touched on it previously, and we were even talking about your remarkable people with proprietary interests that are trying to hang on to data for their own purpose and power. So I think until we grapple with that, we're not going to solve this systemic issue. I also want to go back to the comment about Scandinavia, and my background is actually in technology but in financial services. So really what I'm seeing in health, where we're putting in EHRs and core medical systems in a sense, is what we were doing in banking 20, 30 years ago with core banking systems. And you might recall we used to have to go into the banks all the time. You know, the whole business model of how we transact has changed and share data, not just at a local level, but globally. You might remember back in the days when ATM machines started coming in, that you could only use the ones that belonged to your bank. In Scandinavia, they didn't allow that from the get-go. If banks had ATMs, you were able to use any ATM. It didn't matter what bank it was from. So I think some ways we need systemic things like that, and at a government level that just knock out some of this nonsense that goes on in terms of helping us build trust, but also putting in place things that we can trust you because we know there are regulations in place that if I give you my data, you're going to do the right thing with it.
Yeah.
Could I just offer just one very quick comment, because it talks about trust. With my health economist hat on, I know I think there's at least Paul's here as well as another health economist. There's probably not a lot of us here, so I'll fly the flag for the health economist. Trust equals efficiency, distrust equals inefficiency. If the trust is in something that is trustworthy, right? So we need to be trustworthy in what we do and how we do it. And that generates efficiency, because a lot of the problems that we're talking about stem from distrust. And now distrust can be the right response if people aren't trustworthy, if organisations aren't trustworthy, and if use of people's data is not, they've done things that are untrustworthy with it. And so we have this situation where we have a whole suite of regulation at data custodian level to stop the edge case of someone misusing it. I can tell you, I couldn't count on one, I couldn't count even 10 researchers I know who would ever do anything wrong with the data. They just want to do the right thing. And so if the level of trust I had in the colleagues I work with was transferred to the custodians, we'd have a lot less delays. But it's tricky, because if it's just that one edge case, and I know Ahmed and Harrison are in the media this week, but we do see those cases always pop up. And so it's those ones that where there's no social license, where there's some big concern, and very legitimately, I'm not discounting that, but it's that balance between trust and trustworthiness that is going to depend or influence how efficient we can make systems, I think. Yep.
Yeah. Claire, can I turn to you and just ask about the safe environments for analysing and supporting the data sharing? Is that a government responsibility in your mind? What's the role of the academic sector in that? How does private industry engage in those safe spaces? Claire. That was to you.
Was that a question to me? Sorry.
It was.
that question
Sorry.
to me? Yeah, all right.
I'm looking directly at you on the monitor here,
No,
and I know you can't
okay,
see
that's
that.
all right. So, in my view, the government does struggle to fund research infrastructure for very good reasons. You know, the government is paid by the taxpayers to deliver services. And so I'm really respectful of that. So I do believe that the academic sector has a role to play in building out research infrastructure. We were quite comfortable doing that when it was our own research infrastructure in our own institutions. But I guess what I'm asking to happen now is that the academic sector needs to invest in real-world data inside operations. So that means that we have to give up some control. We may actually have to give funding to the government to allow this to happen. And I don't think that's a bad thing. I think that builds trust, it builds collaboration, and we need to acknowledge, in the same way, if we wanted to generate data from animals, we would set up an animal lab and we would invest in that infrastructure. We can't expect to be handed real-world data. So we need to build out the equivalent of an animal lab, a data lab if you like, where it matters. And so digital health is not free. There's huge amounts of money needed to extract that data to continue to maintain those assets. And if we want to use it for research, I think we have to put our money where our mouth is and accept that it is the equivalent of a wet lab and build it.
Thank you for that. Sharon Goldfield, and then the question over there. Can't see who that is.
Thanks very much. And I wanted to give us a sense of optimism and a bit of hope. I'm part of a very exciting project in Victoria called Generation V. So we've recruited almost 50,000 babies and their parents into a cohort, which we're busy trying to link into a whole lot of things. And just to the point of trust, that's 50,000 families that have trusted us. They have consented to have all their data linked to anything that moves, or doesn't move in this case. And so I just want to really emphasise how important it is for academics to be at the forefront of building that trust and the social licence with families, and that they actually will opt in when you do that. We've, not government collecting the data, but actually academics trying to build the data platforms that we can actually use for research. So that's the first thing to say. It is possible, it can be done. It does cost crap loads of money, so beware. The second is there's a really interesting environment happening, and I think Claire was alluding to this. There is the government is committed to building the Australian National Data Infrastructure, which is essentially trying to create federated data. The National Data Commissioner has sort of said that this is kind of where we want to go. The states and territories are working with the Commonwealth to build these FEDs. So there's a National Disability Data Asset that's being built. There's a child wellbeing data asset that is being built. So I think it feels like everything is moving in the right direction, as well as the fact that, I don't know if you all know this, but there is we all actually have a unique identifier. It's not the Australia card, but we do have a unique identifier which sits under Medicare, which is a Medicare PIN, and it's actually being used now to link a lot of data, health data. So it feels like we're moving in the right direction to expedite our ability to be able to use linked data, and we're trying to think about how do you bring cohort data and linked data together. And then alongside that is open science and the whole generation of what's happening with open science, and the fact that you don't get to hold on to your data anymore. That's just not the way we do things. You are going to have to make your data available to everybody and work out safe ways of sharing it. That is just the way the world is going. And the third concept, which is taking on a lot of momentum, is the idea of data democratisation. So not only how do you get data into the hands of us as researchers, but actually how do you get the data into the hands of communities and community organisations. And at the heart of that is equity. And I think we have to be careful that we don't end up designing a system that's great for researchers but not so great if you're a poor researcher or if you're a community organisation or a community. And if we don't design with that from the beginning, we'll all sit here as very happy academics just perpetuating the inequities that we just talked about in the first session. So I just wanted to put that on the table because it does feel like there's a sense of momentum, and it would be great to see, I've been here for like 2 minutes, but it'd be great to see the Academy put their hand up and really from a policy and advocacy point of view, really kind of spearhead that momentum and also have equity at the heart of that as well.
Thank you, Sharon. Yes.
Hi, thanks. My name's Natalie Taylor. I'm from the University of New South Wales. I'm an implementation scientist, and one of the projects that I lead is to integrate precision oncology into routine healthcare. And one of the things, I'm so glad to hear what Claire said just now, was that we actually tried to think ahead, firstly to build the relationships with the health system, but also then to incorporate additional funding to employ people from within the health system to help extract the data. So in addition to the clinical positions that we fund through the grant. And that has then led to being able to work together to figure out a more efficient approach to ethical access to the data and sharing that data between the system and the university. So that's been a really good experience, as much as it's taken a long time to, get to where we want to be. But the thing that I'm a bit, I'm wondering about is the intended impact of the precincts. So there's all these health precincts that are being set up across different states in Australia, and when I asked the question to those that are leading the charge with that, there doesn't seem to be a sense that there's going to be a foundation set up for more efficient access for researchers to the health system, for efficient sharing of data. And I feel as though this is a really apt time, especially when the precincts, some of them are in the really early stages of being established, to set this, foundation. But I kind of get the sense it's, these health systems and the universities, yes, we're going to still work together, and there's a tunnel that will join the buildings up, but there's not actually going to be, some formal policies that enable researchers to, do the work and be trusted in the way that we really deserve to be trusted in.
Great point. Are you going to answer that point? No? Anyone want to comment on the role of the precincts?
It's a bit like the ATM machines, isn't it? We need to be thinking about it now, so we set it up so that we can share. I think it's a really good point, and I guess, if you're involved in a precinct, to be thinking about how you do that.
Maybe that's something John Prince can take back to the translation centres. Yeah.
I was just going to say there's a lot of places in the world where the line between an academic and a clinician working in a university hospital, for example, is not that. Yeah, it's and so there is actually shared access, and this is not like this hasn't been done before. But just want to agree 100% now that in Australia, I'm not sure we're seeing that level of integration planned, and I know. I can think of a few conversations I'm involved with different precincts where that's actually the start of the conversation. People are thinking, let's build the tunnel and let's connect all the digital systems and let's have a single ID card and a single login I can use on both systems. I'm yet to see it come to fruition in any precinct, despite people's best intentions,
Okay, now we're getting the wind up. I'm sorry. I see a question there. Comment. Been great comments, great participating audience, but the panellists have been absolutely wonderful. Thank you. Great having your expertise. Claire, thanks for dialing in remotely to this. This conversation could go on for a long time. I did want to ask you, Ben, about synthetic data, because that's such an interesting topic, but that'll have to be for
Reach out to me offline.
Yeah, wonderful. Look, thank you so much, Russell and panel, for another great conversation. There's so much more to be said. But I certainly don't want to take up any further time because we have another fabulous panel session coming up. So thank you, everybody.